We're recording? Okay, awesome. Hello, everyone. We're going to get started. So my name's Chris. I'm a second-year medical student at George Washington University and the chair of the Washington, D.C. Emergency Medicine Medical Student Council. I'm excited to welcome you all to our panel exploring racial disparities in emergency care this evening. We have an amazing group of panelists planned, and I'm looking forward to a great conversation. So just to talk through the agenda for this evening, we're going to have some introductions to start, have about a half an hour panel discussion, and about 15 minutes for Q&A. As we go along, feel free to place questions into the chat, and we'll address them when we get to the question and answer session. So just a little bit of background about who we are as the Medical Student Council. So we're the DC Emergency Medicine Medical Student Council. We're a group of medical students from the 3 district medical schools. So that's Howard Howard, Georgetown, and George Washington universities. And we work to connect students to opportunities and resources in emergency medicine and promote interest. We share all of our opportunities and events directly with the DC EMIGs or their equivalents at each school to share with their students. But we also share all of our events and opportunities on our Instagram page, which you can see here. So this is our entire board. I want to highlight our health policy and advocacy co-coordinators, Nelly, Pranav, and Rasha in the top right here. They are really the backbone who got this event together tonight, and they coordinated everything. So a really big shout out and thank you to them. So to get things started, this is our panel for this evening. And I'm going to go through some introductions. We have a lot of panelists, and they all have very long and very impressive bios. So I'm going to pick some highlights just so we can get off to the discussion and conversation. So to start, Dr. Haywood, or as I know, Dean Haywood at George Washington. Dr. Haywood was born and raised in Washington, D.C. She completed her early education in the D.C. public schools and earned a Bachelor of Science degree in biology from Howard University. She received a second Bachelor of Science degree from the George Washington University School of Medicine and Health Sciences as a graduate of the Physician Assistant Program, and had a brief career as a PA before matriculating to Howard University School of Medicine, where she graduated with honors in 1986. She did her residency training in emergency medicine at GW and joined faculty there in 1990. She served as the student clerkship director and the residency program director since. In 2000, she joined the administration and as the assistant dean for student and curricular affairs, and was appointed associate dean for student affairs in 2013, and became the school's inaugural dean for diversity and inclusion. Her work in diversity and inclusion is highlighted by her interest in unconscious bias and how it affects individual and institutional culture. She completed training as a facilitator in the area of unconscious bias in conjunction with the American Association of Medical Colleges and Cook-Ross Incorporated. Dr. Haywood now serves as the interim senior associate dean for diversity and faculty affairs while maintaining her student affair role. Dean Haywood has 3 children and 7 grandchildren. So thank you, Dean Haywood, for joining us. So Dr. Ellis, let me pull up your bio here. So he's currently a medical education fellow within the Department of Emergency Medicine at Beth Israel Deaconess Medical Center and Harvard Medical School. He graduated from Howard University and then went on to complete his residency at the Mayo Clinic, where he was recipient of the Golden Stethoscope Educator of the Year and also the Gold Humanism Award. His career interests are in medical education with specific passions for diversity in medical education and also health equity. He's taught didactics in racial disparities and on health equity. This year, he was awarded the 40 Under 40 Leader in Minority Health Award. He is of half African American and half Mexican American descent and a proud member of the LGBT community. So thank you, Dr. Ellis, for joining us. Dr. Brown, we have a few Dr. Browns this evening. This is Dr. Italo Brown. He is an emergency medicine physician and clinical instructor in social emergency medicine at Stanford Hospital. Throughout his career, he's been at the front lines of social medicine and health equity. He's a former board member of the Tennessee Healthcare Campaign, an organization that spearheads statewide advocacy efforts in support of the Affordable Care Act and Medicare and Medicaid reform. He trained at Jacobi Medical Center and Montefiore Medical Center, 2 Bronx hospitals ranked above among the top 20 busiest ERs in the country. He's an avid writer. He also nurtures a passion for pipeline development, working as a mentor with Tor for Diversity in Medicine. His latest role as Chief Impact Officer of Trap Medicine, a barbershop-based wellness initiative based in California, focuses on strategic partnerships, community outreach, and advocacy. So thank you, Dr. Brown, for joining us. Let me pull up the next one. So Dr. Cortland Brown, a graduate with honors from the University of Chicago and matriculated to the Yale School of Medicine, where she received the Parker Prize given to the graduating student who has shown the best qualifications for a successful physician, and the Grandin Prize given to an African-American graduate student who has shown excellent academic achievement. She completed the NIH Howard Hughes Medical Research Fellowship and received a certificate in leadership in diversity, equity, and inclusion from Cornell University. Her research has affected change at the national level for patients who are primarily non-English speaking. She also held multiple local and national leadership positions, including Student National Medical Association National Vice President and Strategic Planning Council member, National Chair of the American Academy of Emergency Medicine Resident and Student Association Diversity and Inclusion Committee. She was co-leader of the UCSF Emergency Medicine Diversity Group and co-leader of the UCSF Emergency Medicine Quality Improvement Group. She completed her residency at the University of California, San Francisco, where she also served as chief resident and was awarded the Chancellor Award for Dr. Martin Luther King Jr., one of the highest institutional honors that is given to an individual who has demonstrated outstanding commitment to the ideas of DEI. Dr. Brown joined Atrium Health Carolinas Medical Center faculty in 2020 as the department's Vice Director of Diversity, Equity, and Inclusion. So thank you, Dr. Brown, for joining us as well. So Dr. Mitchell. Dr. Mitchell is an emergency medicine physician and instructor and an attending at the Mount Sinai Hospital in New York City. She earned her Bachelor of Science degree in psychology from Columbia University before continuing on to obtain her medical degree from UCS Keck School of Medicine. She completed her residency training in emergency medicine at Jacobi Montefiore in the Bronx before joining the faculty at Mount Sinai. Her professional and personal interests have long aligned with the goal of promoting diversity and inclusion in spaces historically closed off to marginalized people. Dr. Mitchell currently serves on the executive board of the Academy for Diversity and Inclusion in Emergency Medicine and serves as chair of the SAEM Equity and Inclusion Needs Assessment Committee, tasked with surveying the needs of EM-bound medical students from HBCUs and Puerto Rican medical schools. Thank you, Dr. Mitchell, for joining us. And Zachary Brown. Zachary is a current Howard University medical student, and he was born in the city of Wichita Falls, Texas, where he grew up with his mother and two younger brothers. He became the first high school student of his family and continued his pursuits at Vanderbilt University, where he graduated as a top 20 senior with a neuroscience and medicine, health, and society double major, with a concentration in race, health, and inequality. During his time as Vanderbilt, he served as a prominent advocate for his community and peers during the Black Lives Matter movement. This would serve as the catalyst for his passions to not only become a medical doctor, but also become a voice for communities that were similar to his. While at Howard, he currently works with community leaders and nonprofits to expand the reach of HUCM so that we may better serve as advocates and leaders in the community. As a first-generation high school student and now a third-year medical student who is interested in pediatrics, his passion for uplifting Black communities are rooted in his upbringing and desire to change the narrative for his community. He intends to change the face of medicine so that young men who look like him and grew up in similar conditions know that anything is possible. He will become the change that he wants to see. Thank you, Zachary, for joining us. And now off to our moderator. So our moderator for this evening is Dr. Lynelle Campbell. She is a chief resident in emergency medicine at Jacobi Montefiore Medical Center in the Bronx, which we have seemingly a lot of people from this evening in New York. Dr. Campbell received her medical degree from Howard University College of Medicine. She is the former chair for the Diversity Inclusion Committee of the Emergency Medicine Residents Association and the chair of the Resident Committee for the Academy of Diversity and Inclusion in Emergency Medicine of the Society of Academic Emergency Medicine. She is the resident lead of the Jacobi Montefiore Social Emergency Medicine Committee, as well as Medical Justice Alliance, which reviews medical cases and advocates for the early relief of prisoners during COVID-19. She is also currently a fellow for New York City Health and Hospitals Healthcare Administrative Scholars Program, where her focus has been achieving health equity through quality improvement. She is heavily involved in resident advocacy through her work with the union, the Committee of Interns and Residents, currently serving as New York Regional Vice President, as well as Patient Care Trust Fund trustee. She is involved in research regarding medical overuse and health equity research. Dr. Campbell's interests include mentoring, increasing the recruitment of individuals historically left out of medicine, writing health equity and social emergency medicine focused curriculum, and security and workplace violence. Outside of medicine, Dr. Campbell enjoys cooking, Afro-Caribbean dance, spending time with her dogs, and caring for her collection of 60 plus houseplants. So Dr. Campbell, thank you for being here and moderating our event this evening. I will pass things off to you to get started.
All right, thank you so much. I know that those were a lot of introductions, but we've got some real heavy hitters on here tonight. So I just want to welcome everyone tonight for taking the time out of your evening to join us tonight for this very important conversation. I'm just going to get right into the questions because we only unfortunately have an hour for this. So the first question is going to go to Dr. Mitchell. Are there specific aspects of emergency medicine that you think are more prone to bias and discrimination?
Wow. I think that emergency medicine as a whole is very much, we're considered the safety net of the entire medical system. We don't have the luxury of being able to cherry pick our patients and to, refuse to see patients because, they don't have a certain insurance or because they're difficult. So I think just by virtue of being in the emergency department, it's come one, come all. And so for that reason, we really are, for a lot of people, we are their primary doctor. And we're charged with solving a lot of issues that aren't necessarily within our purview as medical doctors. So I think that there are a lot of interactions that we get in the emergency department that you don't get in other areas of medicine. We see people coming in, brought in by police, for example. So now we have to interface with the patient and also law enforcement and also kind of have to navigate those situations. We have people coming in who are highly, disenfranchised and don't have a really adequate way of accessing medical care other than to come to the emergency department, regardless of whether or not it's an appropriate ED visit. So I think that just EM in general is really kind of, ideally it attracts people who want to treat people who are most disenfranchised, but unfortunately, there's a lot of folks in our field, as in other fields, who aren't necessarily attuned to those issues and aren't necessarily very cognizant of the fact that, our patients are fighting several battles. And quite often, the issues that we have to address are so far beyond medicine. Like we're treating medicine, but also it's, okay, let's treat the stuff behind the medicine. Why didn't you get your medication in the first place? Why weren't you able to get to clinic? Oh, because you can't afford transportation. Oh, because you live in the shelter and you can't leave your kids there. So now your kids are here with you and that's a barrier. And, so I think that it really does call for folks who are attuned to these issues and are thinking about these issues. And if you're not, it can be really catastrophic because again, we are the safety net for the healthcare system.
All right, thank you for that. I'm just going to throw the question also to Dr. Cortland Brown and Dr. Itala Brown. What do you guys think? Anything to add to that?
Yeah, I think that was a great overview and great perspective that I 100% agree with. I think the one thing that I would add is, in particular, I think our diagnostic aspect of emergency medicine is really prone to our biases. And we're kind of taught this all throughout medical school. You see your step one question, a African-American woman comes in with a cough, what's the diagnosis? You're taught to think sarcoidosis. And so we kind of have that race association with disease rather than the health disparities that are associated with the race associated with the disease. And I think that mindset, as much as we try and fight it in emergency medicine because we are the safety net, I think that really promulgates itself. So I think diagnostics is probably the one aspect. And there's a recent paper, I was just looking up the title of it, but it's called Hidden in Plain Sight. I forget the rest of the name, but it's talking about how all of the clinical decision tools that we use, as well as all of the measurements. So GFR, glomerular filtration rate, how there's a lot of racism and sexism behind all of those. So I think, you know, mainly our diagnostic, what we're thinking about when we first see the patient.
I agree with both statements. I mean, medicine in general is historically taught through a non-minority friendly lens. We could go through critical race theory. We could talk about the experimentation on Black bodies. We could talk about various layers of this. I'm sure we're going to allude to it later. But at the end of the day, what I was going to say is that I think emergency physicians are uniquely tooled to address these issues and from a different way. You know, we are expert communicators, in my opinion. The ability to navigate someone's life within 8 minutes and get as many details and extract that. And then to see all the corollaries and communicate across and upward, like this positions us to answer these issues. And so it's almost, to me, very fitting that social issues kind of blend into the way that we give care. And the one thing we've done forever is kind of ignore that there is a underlying racial component to these things, that there are clear ethnic discrepancies. And now we're kind of thrust into a position where not only is it in our faces, and we've kind of seen the way this is built over time, we also can do intervention. And that's something that a lot of specialties don't have the full capacity to do.
Okay, excellent. Okay, thank you for that. So moving on, the next question is really around these 3 articles that were posed. And I think we're gonna put the articles in the chat as well. I'm just going to sort of briefly describe what the 3 articles were, and then the question is going to be for Dr. Cortland Brown, and obviously for the rest of the panelists, but primarily Dr. Cortland Brown. So the first article that was sent out was called How We Fail Black Patients in Pain. And what really came out of this was sort of, they looked at a medical school in Virginia, and they polled students and people without medical training as well in the area to ask them about, you know, their thoughts about pain and between Black and white patients. And one of the outcomes of the study showed that about 63% of adults without medical training thought that Black people had thicker skin than white people. When they polled the medical students, 60% of first and second year medical students thought that Black people had thicker skin than white people. And then residents, it was up to 89% of residents at the school thought that Black people had thicker skin than white people. The second article was a meta-analysis and a systemic review, and this was done in 2019, looking at treatment disparities in pain in the pediatric population. And one of the things that they found, so they were looking at pain in UTI, they were looking at pain in other conditions as well. And they found that 22% of the Black and African American patients were less likely than the white patients to receive any type of pain medication, whether it was a traumatic pain or traumatic pain, surgical or non-surgical pain. And also 29% were less likely to receive opioids for similar painful conditions. And the third article was is about like the influence of bias on treatment. And they found that as pro-white bias increased, prescribing narcotics for Black patients actually decreased. So obviously this is a huge problem, and we've seen it in specific diseases such as sickle cell anemia and things like that. But my question for Dr. Cortland Brown is this something that you see in your daily practice?
It unfortunately is definitely something that I see. You know, within the adult emergency medicine, within the pediatric emergency medicine, there's so many implicit biases that we all have, and we all kind of promulgate these issues. I think there's now more of a nationwide trend to be aware of our implicit biases. So I think, kind of like the other Dr. Brown said, we're at a really unique moment in history where we, especially as emergency providers, have a major chance to change the outcome for these patients. We can step in, you know, if I'm signed out a patient who is a sickle cell patient and they said, you know, I think they're just drug seeking, so I'm not going to give them any morphine. We have the opportunity to step in there and educate our other colleagues. So it's definitely happening, but I think there is a change that's coming and is already slightly occurring. So this is a really exciting time in emergency medicine.
Okay, good. Dr. Itala Brown and Dr. Mitchell, if you guys have anything to weigh in, do you see this in your practice? Because I know, Dr. Itala, you're out in California. Tiffany, I know you're in New York. You know, is this something that you guys also see?
Absolutely. I mean, and it's sad because you even hear it from residents, like, you know, who are early in their training. You know, you'll have a patient come in, like, you know, a sickle cell patient or someone who just has, you know, pain, who has a painful condition, and you'll hear the resident almost proudly saying, "Oh, I already told him he's not getting any opiates." And it's like this point of pride that, you know, you're not, and I really think that I think a lot of it is very much couched in, you know, concern about the opioid epidemic and you know, drug addiction and things like that. But really, I mean, I think we need to be really careful and really intentional when we talk about, you know, addiction and the very real concerns about getting people addicted to you know, strong opiate medications, and also treating people's pain. And I think that it's really important that we don't conflate the two. And you know, specifically with regards to sickle cell patient, less than 1% of sickle cell patients meet the criteria for opiate addiction. Less than 1%. So when we talk about the opioid epidemic, this is very much distinct from sickle cell patients. So that's number one. And number two, you know, I don't think that we, specifically as emergency medicine prescribers, I don't know that we are, you know, I don't know the issue is starting with us. I don't know that we have a lot of people that are saying they got hooked on medications because they got a dose of morphine in the ED. Is there a very real, you know, are there drug mills? Yes, there are people that are, you know, inappropriate and irresponsible prescribers, but I don't know that we're doing anyone a service by saying you're not going to get even a single opiate from us in the ED. I think we really need to reframe how we talk about pain and what it means when we say that we don't care about your pain, and what that does to us and what that says to our patients. You know, I think that there's a very real empathy gap that's happening here, and there's absolutely a racial component, in my opinion.
I keep my statement really short, or as short as possible. First off, Tiffany, excellent way that you put that in Cortland. That was a GOAT answer for real. I think that so Tiffany used to be my resident, and she actually wrote a really cool piece about this when we were in residency. And I like to reference historical examples. Like, this is not new, you guys. I'm gonna keep saying this over and over. This is not new. In 2000, I don't know if you know Prodigy from Mobb Deep. I'm a hip hop fan. He had a song called You Can Never Feel My Pain. And he talks about what it was like being a young person going through sickle cell and people believing that he was a drug addict, even though he was just in pain, and how he was essentially grew mistrust with the medical system because of it. So this is a story that happened 20 years ago from someone who unfortunately died, and does so much for our culture as far as hip hop. Now, fast forward to the various ways that this manifests. It's not always just about sickle cell disease. You can see this in the treatment of African-American patients being given hallway beds more likely than being given rooms. You can see this in activation of cardiac cath labs. You can see this in a variety of different outcomes and clear endpoints. The things that I actually feel worse about is we haven't gotten up to a point where we've analyzed mental health disparities enough to know that Black people even have disproportionate treatment in their mental health in the emergency department. The likelihood of being restrained, the likelihood of being given chemical restraints, like chemical sedation, like all of this has a deep ethnic origin, or has a root that can be due to implicit biases or underlying underaddressed racism. So with that said, I think the one study that you mentioned that we really didn't hit on was how current medical students may still believe that there is a pain differential just because you have Black skin, right? Like, so that's more troubling to me than knowing that there's a consistent way that we've been treated in terms of pain medication, is that we're producing new physicians who still think like old physicians.
And to touch on that, like, what, you know, it's really important that we recognize that these thoughts didn't just, you know, evolve out of nowhere. This could be dated back to the 1800s. This is literally based upon findings that were studies that were conducted by really problematic pseudoscientists who were doing these horribly unethical tests on enslaved people. And all the findings are developed to support the further subjugation of Black people, saying that their skin is thicker, therefore they have to be whipped, and they have to, we have to subjugate them for all these medical reasons. And so these opinions are very much can be traced back to some really, really horrifying, pseudoscience data. And it's sad that it's still persisting today. And we have to think about why it persists. Like, why are we still, well, it persists because we haven't really analyzed, we haven't really thought about it. We haven't thought about it critically. But I think one of the data points that I found most interesting from one of the papers you sent out was that white race, in the meta-analysis of all these pain studies, it found that like white race was more predictive of whether or not you be prescribed opiates, even more so than the presence of a traumatic injury. So, there's this concern about, opioid misuse and addiction in the Black community, but no such concern for whites. There's no worry that, sending home, a white patient with 20 Percocets is going to result in any kind of misuse or maladaptive behavior. But there's this very, paternalistic concern when it comes to our Black patients, and it's very telling.
All right, thank you guys for that. And I think it leads into sort of the next question. And
Yolanda, did you have a comment?
Oh, sorry.
I was just going to add that I think, Tiffany, you hit on a very important point, which is something we haven't mentioned, and it's white supremacy, which is pervasive in our country. And, when we talk about the history of slavery and all the things that you mentioned, I mean, I remember, I just read about, I'm blanking, Dr. Cartwright, he amputated slaves' limbs without any anesthesia, and bragged and wrote about how he did it without anesthesia and how he knew these people didn't feel pain because they held the limb for him while he amputated it. I mean, this is the kind of stuff that lives forever and ever and ever. And I think one of the reasons it hasn't been dealt with effectively and why racism is so pervasive is simply because we live in a country where white supremacy reigns. And we haven't been able to say those words. We just haven't had the freedom to say that's what lives and keeps racism alive. And I think we just have to keep saying that and make sure that we understand that that is a truth. And it's not to blame any white person that hears those words specifically. It is our history, and it's ingrained whether we like it or not. And that's what we have to change.
That's an excellent point, Dr. Hayward. Thank you. And it sort of leads into the next question. We were just discussing about how this is coming out of medical schools, and these studies were done less than 5 years ago. So these are people who have now graduated medical school, they're in residency or they're in practice, and some of them are even teaching young medical students. And so this next question is for our student doctor on the panel, Dr. Zachary Brown. Why do you think that, one, the history of some of the things that we've just mentioned is actually left out of medical education? And why do you think that it's been so taboo and not necessarily a priority to teach health equity and to teach about bias in medical schools?
I think the big part as to why that isn't brought up in our education is also why it isn't in our country overall, because then you have to now acknowledge that we played a part in all of this. It is for every health person in this field from way back, and then to even now, you would then have to be very honest and very horrible in the fact of we play a part in it. And I think it's been proven in 2020 that acknowledging is a huge issue. But I think that becomes a problem for our Black patients, for our Hispanic, and all of. I think if we don't begin to truly acknowledge the history, then we won't ever be able to move forward. And so I think that is it's just it. And so the other question was, what else?
Oh, it was, oh, my headphone's falling out. Why do you think that it's taboo to sort of have these discussions about health equity and bias and race in medical schools?
And I think that also fits in it. I think the issue at hand is that then will have us having to look inward, and having to now acknowledge the part that you as an individual and you as a group and us as a whole play into this system. I think as a student, and also as any program, I think one huge issue is that there are still programs out here where there are no Black, there aren't any Black folks in it. There's no brown planet, and that ends up being this huge issue because folks will still come in with their own people will come in with their own implicit biases, and if you don't have a program where there are others in that program to kind of check it, then it just keeps on this whole cycle of this same thought process. And so I think it is still very present because there are still programs out here that aren't as inclusive, and so it will just keep on until we are very active in creating spaces that have more of the voices from these groups of people who are also heavily impacted. So.
Excellent points there. Do any of the other speakers want to weigh in on that as well?
Yeah, I think you made some really good points, Zachary, and I think sort of the crux of it is, your question is why haven't these things been taught? And I think the answer lies in racism. And when we talk about racism, I really love Kamara Jones's definition of what racism is, because sometimes I think we're talking about racism and we have some abstract ideas about what that means. But, and I always refer to her definition when I'm thinking about it, because it helps me to come back to the critical points that we need to be thinking about. And she says, racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks that unfairly disadvantages some individuals and communities and unfairly advantages other individuals and communities. And finally, it saps the strength of the whole society through the waste of human resources. And so when I think about why we haven't been taught about our history, it's because the system is designed to unfairly disadvantage us. That's what it's designed to do. And so as we think about how we have to intervene, we have to think about how do we dismantle these systems that are in place. And I think that's a very a focused agenda. How do you dismantle a system that's been in place for over 400 years? So we have a lot of work to do, and I am impressed with this group. The panelists are awesome. I think we can do the work.
Yeah.
All right. Excellent, excellent. Okay, so obviously there is a lot of work to be done, and again, and I'll say this again, we only have an hour today, but this is a conversation we can obviously speak for hours on and days and years about. But just moving on, so I think we touched on some of these things, right? Some of the things that we can do, and I saw some of the questions pop up in the chat, people asking, how do we actually do this work? And so this is actually for Dr. Itala Brown and Dr. Haywood. How do we go about closing this gap, both in patient care and also in education, so that we improve these outcomes for our patients, essentially?
I want to defer. If he's there, you can go ahead and speak first, but I don't mind. I feel like I've talked a couple times today. All right. Well, then. I'll give it a shot. So I'm assuming you meant in education of our students, right? Mm-hmm. So you said patients and in educating students. So the first one I'll answer is the students part, then the patients. We have to do a better job of integrating health equity and social justice in the curriculums. Like, that's just the answer to that. I mean, there's some stunning examples of where we're seeing it happen. And I think that you can tell by the way that the students report their satisfaction with the material and the curriculum, and the fact that you see these issues being almost championed at the student level. Like, that's the real key. It's like, it's not faculty driving these changes. It's actually students who are saying, I want to know this. I want to feel like a provider of the future. And so it requires me to have as many tools as possible. And that means developing a compass for social justice and a lens for health equity, so that you can give optimal care. The other thing that I was going to say is, in emergency medicine specifically, there are ways to do this with real live examples. You see a patient who doesn't get dialyzed and you wonder why. I mean, this is a treatment that you need to live. And you have to really break down the social underpinnings of why people miss dialysis. That's a conversation about equity right there. And so we have these micro opportunities to really have these dialogues on a regular clinical day. And that happens more commonly in our specialty than a lot of other ones. So there's the clear nexus for that in our specialty. And I'd also add that it never hurts to have a health equity rounds or a racial justice rounds and just talk about some of these societal things that we see. Now, to your second point about how it extends to patient care, I think that this is a little bit more of an enigma, because you're fighting a bunch of different things at once. It's not impossible, but it is an enigma. Because I think that you have to first get the clinicians to see that there is something wrong. And that's what we've been working so hard to do and pushing so hard to do, is to say, like, hey, we have been doing something a way that has completely selected against an entire group of people or entire groups of people. And now you're doing the back education. So the steps have to start with doing the education, and it can't always be driven by people of color. It can't continue to fall on the shoulders of people who look like this, who experience this, who have racial trauma that is re-experienced every time they teach these lessons. So I think that it makes sense to try to put the onus of doing the work, kind of share it, make sure that you are able to tell these things, but there should be homework. People need to take that advantage of being an adult learner and educating themselves on these structures and systems that have systemically disadvantaged certain people. And then I would say, once that kind of starts to filter, you can create programs that approach community members, that bring them on as stakeholders in the emergency setting. So it's not always just like, hey, we're this system that continuously, essentially like neglects you. We get your feedback. We understand what your resources that you're not getting and the things that you need in a community to support its infrastructure. And then you create programs to start to deliver those things.
I love what you said about micro opportunities. I'm going to use that. That is an excellent description of an opportunity that we all have as people who provide care for another person. We have these micro opportunities, and every time you have an opportunity to intervene, that makes a difference. I could tell you stories in my own life about how the intervention of somebody who doesn't even know now that they changed my life. They changed my life. But to get to try to answer your question, Dr. Campbell, I think, so for me, the strategy is, one is personal. So what does that mean? That means each one of us have to do due diligence when it comes to understanding history, understanding racism, and understanding where we are, how are we continuing racist practices. And that may seem like a crazy thing to say to a group of people of color, but we are not exempt from holding racist ideas.
Say that again.
Yes.
We are not exempt, and I would ask every single person on this call to spend a few minutes thinking about how you are allowing racism to continue. And I mean that to say not only you participating yourself directly, but even you standing by and allowing things to happen, particularly students. I believe that students have a lot of power, but all I hear is, no, students are too afraid to say anything because it might cost them a grade or it might blah, blah, blah. I believe you can be fierce. Students, you have the power to change an institution. I believe that 100%. Okay, so I'm gonna get off of that soapbox, but I believe you have a personal responsibility, number one. Number two, there's an institutional responsibility that takes people doing things. And by that, I mean, the institution has to understand where policies need to change. That means we as individuals have to be involved in committees that make policies, right? And intervening where we can, but there has to be institutional attention to policy and procedure. If the institution doesn't change, the individuals can change all they want to, and it's not gonna move the needle one bit. Institutions have to change. And then thirdly, we have to change society. And what does that mean? That's the health policy piece. We have to be involved in helping to change big, huge policies. I mean, big things. And I'm talking about policies like, somebody mentioned GFR, policies like a crazy formula that says if you're a Black woman that had a cesarean section, and we're trying to figure out if you could potentially have a vaginal birth on your next delivery, we put a factor in the formula that disadvantages you because you're Black. I mean, seriously? How long have we known about the Human Genome Project? We're all 99.9 alike. Why you gotta put something in the formula about me because I'm Black, number one. Number two, how Black do I have to be? I got a white grandfather. I don't even know who he is. But I'm just saying, how Black do we have to be? So, I mean, so I say it's personal, institutional, and societal. And we have to find ways of attacking all those. But I'll also say, raising awareness, our awareness is already raised. I'm tired of talking about raising awareness. I'm tired of talking about trying to teach you about your bias. Whether it's unconscious or conscious, I'm tired of trying to teach you about that. I understand we have to do it, but that's not where the money is. There are plenty of studies now that tell us unconscious bias education has not moved the needle. It has not. And that's because ain't nobody changed no policies. Everybody talking about, you know, pay attention to your bias, but it ain't changed nothing. So I'm done with that. I'm ready. Let's move on to changing policy, changing procedure, and then consequences for those who don't want to practice the way the policy says you're supposed to practice. Sorry, I'm preaching.
No, do not, please preach. This is a whole word for everyone on here tonight. And I really appreciate it. And I'll just, I'll add in my 2 cents to my own question. I think it's really important that everybody uses their platform. Not everyone can be a CEO of a hospital. Not everyone can be a resident. Not everyone can be an MD. Not, all of these things, but everyone has to play a part in it. And I think where we've fallen short is that people are not using their platforms. If you are somebody who writes curriculum, you need to use that platform. If you are somebody who creates institutional policy, you need to use that platform. If you are somebody who's creating testing materials, you need to use that platform as well. So I really, really appreciate your comments, Dean Haywood. I think it definitely is a sort of personal and institutional action that we need. And, again, we've talked about it. I think this year has shown that, it's out there. We can't hide from this anymore. So there's no excuse. It's now, what are we actually going to do? And that's something that at the end of this discussion that we're going to actually give all the participants actionable items that you guys can do to actually start this change, whether you're a student, whether you're a program director, whether you are an attending, whether, whatever it is you think you are, who you are, you can actually do something to help this. Right. So I really appreciate that. And so for the last question for the night, from my questions, and then we're going to take participant questions. I've seen a lot of them popping up in the chat. So there was the last article was an article by a former assistant dean from the University of Pennsylvania, Dr. Stanley Goldfarb. And the name of the article is "Take 2 Aspirin and Call Me by My Pronouns." And in this article, he really criticized sort of those woke, quote unquote, as he used it in the article, quote unquote, woke medical schools that were teaching students about social policy and teaching students about climate change and gun violence and, empowering them to be activists. And I'm just going to read a few quotes from the article. And then I want all the panelists to just kind of give, if you had an opportunity to rebut this, to respond to this article, what would you say to this? So the first quote is, "Why have medical schools become a target for inculcating social policy when the stated purpose of medical education since Hippocrates has been to develop individuals who know how to cure patients?" Second quote, "These educators focus on eliminating health disparities and ensuring that the next generation of physicians is well equipped to deal with cultural diversity, which are worthwhile goals, but teaching these issues is coming at the expense of rigorous training in medical science." And now the final quote from it is, "If this country needs more gun control and climate change activists, medical schools are not the right place to produce them." So I'll just tell you personally, this article made me heated, but it's he's not the only person who's thinking it, and this person was the dean of a medical school. So if he's thinking it, there are many other people out there that are thinking it, especially people who are in positions of teaching medical students. So if you guys just want to take, I see the faces already. You guys are ready. So if you guys, yeah, go ahead.
I literally can't. I think it circles back to your original question about why aren't we teaching health equity in medical schools? We're not teaching health equity and racial justice in school. We're not teaching our history in regular schools. This is something, we are a country that has yet to fully, we are a country, first of all, that was literally formed. The very basis of our economy was anti-Black racism. We did not exist outside of slavery. We didn't exist as a country. That is the only reason why we are a power today. And so to say that, that this doesn't affect, I like to say, look, anti-Black racism is as American as apple pie. We are all of us are affected. We are infected with it. We are all born into it and inoculated with this. And we also refuse to kind of take any responsibility and really kind of acknowledge it. And it's endemic. And so I think that, the hardest part is still convincing white folks that there's a problem, convincing them that they're sick. It's the first step is convincing people that think they are good, that believe they are good and unbiased, that they are in fact biased, that they are in fact sick. You have in fact been infected with anti-Black racism. I know if I grew up harboring anti-Black sentiments, I know you did. So there's no excuse. And I think that's still very much the hardest part, and that's why we're not talking about it, and that's why there's so much pushback to any kind of, discussion about it. And so even when it comes to education, we're talking about health equity and we're talking about social determinants of care, it can't be presented as this, extracurricular thing, like, oh, if there's time, we'll talk about it. This is just as important as our sepsis protocols. This is just as important as learning about how to treat PEs and strokes. And I think that that's the hardest part of thinking this, of really kind of taking ownership of the fact that as long as you aren't confronting these issues, if you're not thinking about it, if you're not, watching panels like this, if you don't think there's an issue, you are very much perpetuating this problem. Why is a Black child 3 times more likely to die a month after elective surgery than a white child? Why? Like, we have to reckon with this. And I think that, and by not reckoning with it, and by not really kind of attacking it face on, we're gonna continue to kind of do really wrong by our patients of color.
Right, I really appreciate that comment. I think that's something that you and I have spoken about, sort of this urgency, right? We want, residents to meet standards, for example, in learning how to read EKGs and diagnosing all these things, but we're not holding them to the standards of understanding what is health equity. Especially people who work in areas like, where we train in the Bronx and things like that. Like, how dare you leave a residency program in a low income area like this and not understand how this is impacting the patients that you're training? Like, you are training on these patients' bodies every day, and you don't understand anything about their community and sort of their history. So I really appreciate those comments. Anyone else want to weigh in?
Yes, I do. I think one thing that is huge, and I think is huge at Howard is we are training like health advocates. So at the end of it all, once they come in for help, you are not only helping them in that one moment. They have a whole history that you also have to then also acknowledge. And I think with the people that we see, it ends up being this huge huge issue because yes, we can help you in that moment, and we can say, hey, here's here are a few aspirins now for home. But then once they walk out of those 4 walls, it's a whole world. And so I think I am very huge about is we aren't just doctors, we are truly health advocates. And once we can switch from that understanding of you are treating that patient for, you are doing that whole person from home to the time they sleep. You are still having to help them. And so I think it's just a thing that we as folks in this health field have to kind of we have to kind of switch over into is to think about us as true advocates. And so, yeah.
Thank you for that. And just one of the other things, and I saw just, I'm kind of seeing what's popping up in the chat, really pay attention to the language that's used today, and I think these are words that we need to make sure when we're discussing these topics that we use, things like empathy and passion and compassion, the difference between equity and equality. And, we have to make sure that you know, if we are the people who are doing this work and taking it on and, you know, even trying to have these discussions or trying to even learn about this, that you make sure that you look for those words and you make sure that you use those words, because the language is so important when we're having this conversation, especially with people who push back or who don't really want to acknowledge that there's an urgency for this. Okay, we have to be very aware of the language that we're using and make sure that we're communicating what we are trying to communicate, that we're not sitting there, you know, and misrepresenting, you know, what we want to actually achieve. So I really appreciate it. You know, like I said, I'm just seeing some of the words popping up in the chat, and I just want to make sure that the language in this is just so important. Anyone else want to weigh in before we get to some of the questions that came up in the chat?
I have one more thing to say. I think one thing that we haven't touched on at all is, you know, one of the most important things in your ability to affect change is your own physical and mental health. Oftentimes we take on so much on ourselves and we think that it's our responsibility to make these changes. We're the only ones that can. But if you do that, you are going to be so burnt out. And so constantly checking in with yourself, especially as a student where you're trying to balance literally just passing your clerkships, like that is hard enough in itself. That is super hard. So the fact that you're able to do that is important, and that should be your priority. You know, once you get to these later stages, then you can worry about, you know, becoming a leader, or if you're able to become a leader and balance your clerkships and do everything else, that's fine, do that, but just make sure that you're taking time for yourself.
Yes, thank you so much for that.
I had a couple of things. I don't know if you wanted me to go. I could wait, actually.
Of course, go.
No, I mean, I just was going to say that we also have to remember that there are parts that have to outright be dismantled, right? Like there's something, it doesn't necessarily have to fall on the shoulders of every person who is in the educational process, but those who have gone through and have the ability to look back and see that there's inconsistency between the messages that might show up in a mission statement or in an anti-racist statement, and then what the actual institution stands for, what it projects internally. If you see that incongruence, you have a responsibility to speak towards it. And then I think that there's got to be a normalization of doing that without fear of reprimand or without fear of there being some type of, like, you know, something pulled from you because you have honestly earned your right to be where you're at. The other thing I was going to say is, you know, I made a comment one time in a piece that I wrote where I said every single building that we enter in the healthcare system basically reflects, for the most part, reflects white dominant male culture, like white male heteronormativity. And that is a part of the problem. And so until we start getting to a point where we're calling those things out and making sure that people know that it's inconsistent, then we're going to continue to just like gloss over the problem.
Definitely. Like I said, looking in all these nooks and crannies to see where we can make change, I think is extremely important. Okay, so Chris, I don't know if you want to, or I forgot who was manning the chat, if you want to just pull out some of the questions that were asked. I know we said that we were ending at 8 p.m., but obviously we need a little bit more time to go through these questions. I think it's really important. So we have extended some of the time for this chat. For the panelists, before we start, I just want to say thank you so much for participating and taking your time to do this. This is very important work. And so if you guys want to start reading off some of the questions that came up in the chat.
I can start reading some off, Nellie, or if you have some that you've seen.
Yeah, take it away, Chris.
Okay, so let's see, a lot of questions. Let me see here. So I guess one question that came out was if anyone has seen specific policy changes in their institutions that they can also advocate for at their institutions to kind of improve care to marginalized populations and people of color. So that kind of specific things that they've seen.
I could just mention, I mean, I'm sure some of these things are things that many institutions are doing now, but we have in place now an inclusive committee policy, because in many institutions, committees get formed because a group of typically white men sit around in a room and say, okay, let's have a committee on promotion, and let's have this person, this person, this person, and this person. And when you look at the committee, it looks just like the people who said who they wanted on the committee. So we now have an inclusive committee policy that the final say of how the committee looks goes to the Dean for Diversity. So I think, you know, that's one thing. And if you might know that many institutions have now abandoned the GFR, the EGFR, the use of the race correction. I mean, that's a policy change. That's something that will live forever. And I did want to back up and say one thing about, I forget who said it, but thinking about having the courage to stand up, the courage and conviction to stand up for what you know is right. And it is not always easy, and sometimes the result could, I mean, I'm not gonna try to sugarcoat this. You could be, what's the guy's name, the football player who took a knee and then got fired? Listen, it takes courage to do this kind of work. But if you're doing the right thing, it's worth it. I'll also say that the white coats for Black Lives movement has really pushed institutions. If you haven't looked at their race report card, they've reported on 17 academic medical centers and where they fall in terms of their, how close they are to being an anti-racist institution. And they took this work on before everybody was screaming anti-racism. So, you know, I would say policies like what they're recommending, and some of them are radical things, like we shouldn't look at people's police records when we, you know, during admissions to medical school. I mean, honestly, that's pretty radical when you think about the fact that in order to get a license, you have to have a criminal background check. But anyway, I think there are many institutions have put in place policies. I'll mention one last thing, and that is, I think this happened at the Brigham. I'm pretty sure it did. It was an article. Michelle Morris is one of the authors. You guys may know her name. She's big in the anti-racism community, but they looked at patients who came to the emergency department, got admitted for congestive heart failure. And they looked at which patients got admitted to the general medicine service and which patients got admitted to the cardiology service. And you might say, what difference did it make? It made a whole lot of difference, because what they knew was that the patients who got admitted to the cardiology service had better follow-up and better outcomes. Who do you think got admitted to the general medicine service, and who do you think got admitted to the cardiology service? I don't need to tell you the answer, you already know. So one other thing that we need to be doing is looking at our practice. In your own institutions, in our institution, we're not really examining our own practices to see where we can intervene. So they found out that that was true, and they made an intervention to prevent it. So I think it's hard to be prescriptive about what to do until you know what's wrong wherever you are.
I'm gonna make a couple quick points. First, you said some examples. I'm gonna give a couple of concrete examples, or 3 examples. One is a move towards holistic review of candidates. Like, that to me is in itself a way to try to like get towards that equity point, is making sure that you are not just looking at certain features that traditionally have favored non-Black medical students, or have favored non-UR medical students. Another one that I would say is requesting that your educators in medical education, whether it's GME or UME, have learning objectives that directly speak to points of equity or justice, like to say it, like, so that it's actually in writing and it can be tracked. And you can see over the course of years, based upon student evaluation or evaluation of residents, whether or not it landed well. So that's another policy change that you can do right now. And then the third thing I would say is there is a dearth of information around patient rights, specifically those who are incarcerated. And if you have a task force that addresses this and looks for ways to make sure that patient rights are consistently maintained, you're going to see that first and foremost, we know that there is a racial ethnic element to how these patients present in emergency departments, but protecting them and the education it takes to do that is what gives you the greatest bang for buck. So that's why I say you can focus on that one metric, but in the process of doing that, that means microaggressions training, that means implicit bias training, that means upstander training, that means understanding of privilege, and you get all of that in one particular policy shift. Okay, so I say that because these are things that I've seen happen, that I'm currently doing, and you do get a significant movement in the needle if you address these things.
Okay, and I'll just give an example from my own institution. A couple of weeks back, we were doing a health equity rounds, and it was surrounding patients with sickle cell disease and sort of, what their experience is as they go from the inpatient side, pediatric, and they transition to the adult emergency department and then in the outpatient department. And what came up during the chat or through the discussion was that our institution actually had a policy where patients they would do a urine tox on all of our patients with sickle cell disease, and those who screened positive for marijuana, they would not get prescribed narcotics as an outpatient. And it was one of the, I just remember, I was just like in the chat, I said like, what, exclamation point, exclamation point. And then somebody posted the policy and we just created, in a few days, we looked at that policy and we brought it to the institution and said, this is wrong and this is not right. And it's in the process right now, definitely getting reviewed, and we're definitely advocating for change. And so that was something that just happened in real time. But those sorts of things are extremely important, to really look at those things. And this is a policy that has been around for years, okay? And it just took a group of residents who were just doing a presentation to sort of, bring up that discussion, and this is a policy that goes through, so many different reviews, and everyone's just accepting it. And I think that's the other big part. There are things that are in our institutions that we just accept. Well, this is how we do it, and this is how it's always been. And I think those are some of the most destructive words and dangerous words that we use in our institutions. And as residents, sometimes we take it as, well, we're just the trainees, we're just showing up to try to, survive residency and get out, or survive medical school and get out. And, we can speak up, because I think we also have a different perspective. The people sometimes making those policies haven't seen a patient in years. They don't understand like what's actually happening in front of them and how it's affecting these patients. And so I think, again, it is scary as a resident, because you want to keep your job and you don't want to ruffle feathers, but sometimes, we have to, and I think we owe it to our patients to do that. So it definitely takes a lot of courage. And I think that was a big word that was used today as well. Okay, so if we can, any other questions in the chat?
Yeah, absolutely. So one question, there's a little bit of discussion as well, was in reference to the medical community's violation of trust in the Black community, and kind of asking what steps can be taken to rebuild that trust.
That's heavy. I mean,
heavy and perfectly timed for this vaccine that just came.
It is heavy, right? Because I mean, yeah. we know about the disparities. We know that they're less likely to have their pain treated, and we know that they're more likely to have worse outcomes, and we know that there's so many of our colleagues and who are just not doing right by their Black patients. So it's, how do I convince my grandpa that he should keep taking this? It's difficult. It's very, very difficult. And I think that it really is. It's really tough. And I spoke on a recent panel, I talked to some other providers about it, that like there's a lot of things that it's hard to kind of convince them to have faith in the medical community. All I can do is try to be as good of a provider as I can. And also, we're constantly trying to mitigate the damages that we know that they might face as Black patients. It was another provider talking about how when her mother was having chest pain and went into the ED, and how she was just sitting in the hallway, not on a monitor, no EKG for 1 to 2 hours. And it took her showing up as a doctor saying, no, she needs to make sure these things are done. Like, hey, I'm Dr. So-and-so. can we get the ball rolling? And now all of a sudden things are happening. And it is hard. It's very hard. Every single time I have a relative that gets in the hospital, I'm on the phone immediately. I'm on the phone. Hey, this is Dr. Mitchell, you know, just checking in on so-and-so's care, because I know how these things work. I know that people move different when they know there's another doctor checking their work and actually following up. So I don't know how to, I really don't know how to convince a lot of people to have faith in a community that hasn't yet done the work to earn their trust.
Yeah, I said this in the chat, but you know, I don't think we as a healthcare community deserve the trust. Like, we are still messing up every single day. You know? Yeah, and you know, so we have to make those changes. You know, maybe your aunt trusts you as a medical student and your knowledge, so you can kind of have that individual relationship. But as that aunt, I wouldn't trust the healthcare system.
As a, you know, I've thought about it frequently. I'm like, listen, let me, back in my, how would I be treated if I, came into the ED unresponsive, unconscious? How would I get the care that I expect? Would I be treated like, would they assume that I was some drug overdose? Would they assume, what would be the assumptions made about me if I were in the ED and I couldn't say, hey, hi, my name is Tiffany Mitchell, I'm a doctor, and blah, 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 blah. No, I'm just a black woman. Now it's just me. And I am very, it's scary. It's concerning. And I think it's something that we all think about and we don't want to confront it, but it's very real. It's very real.
I wanted to say a couple points real fast. I mean, this is, whenever I give a conversation around mistrust, I always get as personal as I can, because people think that just because you are a physician that people in your family don't have this same degree of mistrust. And I talk about how it took my father literally years, like my entire process of going through wanting to be a physician, to medical school, to residency, to actually get him to start to follow basic health advice and going to see a physician. And it was built out of, my dad's a child out of the 60s, and his entire understanding and interaction with the health system has been marred by trauma, has been marred by having people look at him differently and treat him differently, and even to the effect of being talked down to or over. And so those things are what we are up against. And I take it as a personal task to start with very clear relationships and trying to rebuild trust at an incremental level. The other thing that I was going to say is, we have tremendous power as providers of color in this conversation. I know that it's not right. It is another minority tax. It is a problem we did not create. But I would rather have my dad getting colonoscopies than sit there and argue with somebody about how the systems of mistrust are the reasons why he doesn't get one. So I do the work. I do barbershop health interventions. I go into communities pre-COVID and have these conversations. They're very difficult because most of the time you're going to be the enemy. Like, you walk inside, they're like, oh, you're just a doctor. But you have to be willing to stand in the gap and continue to have this despite it being uncomfortable. And for colleagues who are not Black that wish to do this, understand that it starts with listening. Like, a lot of this is, you need to understand why the mistrust exists and what those roots are and what those narratives have been like that they've lived through. And then starting to listen is how you gain just an inkling of trust back. And you may not have a Black physician or someone of color to do the warm handoff or the warm introduction that you need to get in these spaces. You have to want to do it. It has to be in you because you signed up for this. And this is a part of trying to give optimal care with a degree of equity.
Right. And just, we go back to the language, and you just mentioned the minority tax. Do you mind just taking a couple of seconds just explaining what that is for people?
Yeah, so I got you. This is I don't know exactly who coined the term, but it's written about in literature as this disproportionate burden on people of color who are in sciences or who are in specifically, well, for this conversation, in medicine, to do the heavy lifting of educating people, or to have all the conversations that circulate around social determinants of health or health disparities. It may also mean taking on the brunt of mentoring people who are trying to come through these same ranks and are underrepresented minorities. It may also mean that if there is a task that requires diversity, equity, inclusion, you get voluntold or selected to do these things more commonly than not. And for students, it may mean that every time they need a diversity photo, you're the one that's getting brought to the table. So this is a minority tax.
And it's for free. This is free labor.
And it's never paid.
Hey.
It's always expected to be kind of like, hey, you want more people who look like you in this space, so let's go ahead and essentially operationalize your Blackness.
Right, and I think
when it comes time for promotion and advancements, is this work weighed as heavily as, you know, some of my white colleagues who were allowed to just, you know, publish, and you know, are my publications weighed the same because they're all in diversity and equity work as someone else who is in, you know, the hard sciences. So it's, you know, we're asked to do a lot of the work and the heavy lifting without necessarily the same, you know, benefits and accolades. So
right. And I think this speaks to Dean Haywood's point about, you know, the structural changes that need to happen. You know, are we, like you said, are we weighting this the same way? Are we, you know, places will very easily take your picture and put it on their diversity poster and say, look how diverse we are. This person's, you know, our one Black resident or one Black medical student. But what are you actually doing? Are you advocating for that student? Are you giving those students those same opportunities? And even, you know, for us, you know, well, I'm transitioning into attending, and for those of you who are young attendings, I mean, I'm because you want to check a box. What happens after that? That I've checked your box and I've made your institution look good, but are you actually investing in my professional development? Are you giving me the tools that I need to even do this work? Are you weighing my work the same way? Are you making my work core work? You know, so I think, you know, those are very important conversations that need to happen. And so I think we should take one more question and then we can wrap up.
Yeah, I think this is a kind of a good follow-up from what the discussion just was. So the question is, what changes can we make in EDs specifically to make them a safer space for minorities? This seems especially challenging since the doctor-patient power dynamic is much stronger when a patient is in crisis and doesn't have the option to choose their doctor or walk out the door if they're not comfortable.
the question was about how to make spaces more comfortable for our non-white patients. Was that the question?
Yeah, it was just saying, you know, what change can we make in the ED specifically to make them a safer space for minorities?
I would say, I mean, just start with kindness. Just, you know, a smile on your face when you talk to people, you know, assuming good intent, even if they are, you know, crazy and annoying and don't smell so great, just kindness. You know, recognizing your biases and recognizing when you're walking into a situation with a bias. I have to do it every single time I talk to a drunk patient because I have a very real bias against people who can't hold their liquor. That is my cross to bear. And so every time I have some angry, belligerent drunk patient, I'm like, okay, if this was my uncle, how would I want him treated? If this was my crazy drunk uncle, how would I want him cared for in this situation? And I think that that's something that we all should just do better about. Like, how would you want your mother treated if she was sick? How would you want your brother who's, you know, maybe, you know, on drugs or mentally ill? How would you want them treated if no one else was there to advocate for them? I think the first step is just kindness. I can't fix every single, and as a new attending, it's very daunting because I cannot fix every single institutional problem at my hospital. I cannot address the fact that certain patients are going to get beds faster than others because reasons. But what I can do is make you feel comfortable while you're here. I can let you know that you're being heard. I can let you know that I'm listening and that I'm addressing your pain and I'm addressing your concerns and I'm explaining to you the medical process 2 and 3 times if that's what it takes for you to feel comfortable. And I think that's the first step. And it's hard because the ED is crazy and it's busy and we're pulled in a million different directions at once. But I think that, you know, kindness is free. Empathy is free.
I think it's important to even extend the question to our non-white providers. You know, how do we help other individuals that look like us feel comfortable in the emergency department? Because it's not just the patients that are getting discriminated against. And so, you know, even oftentimes, you know, you will have one of those drunk patients. Again, I also have a similar bias, but, you know, you will have one of those drunk patients giving a derogatory slur to the med student, the resident, even the attending sometimes. and just taking that person aside and asking them, are you okay? Just letting them know that that is not okay. That is not something they have to just, accept. I think in the emergency department, oftentimes we as providers think that, this is just part of the job. It's okay for a patient to call me, a terrible word. No, it is not. And so supporting your colleagues, especially as a med student, you're in a position where if you see other med students experiencing that, ask them how they're doing. Ask them if they want your help intervening. As a more senior individual, I think it's helpful to not automatically just go in and correct the patient, but to ask the individual that was discriminated against, what can I do to help you? Do you want me to go in and handle this situation, or do you want to handle it yourself? Because, people, especially, although I'm biracial, people that look like me, I don't want to come in as the white savior saying that, don't treat my resident that way. So I think it's important to watch out for our providers as well.
Agreed.
Also, it's okay to overcompensate. It's okay to be extra nice to the person who's not being very nice to you. It's okay to be extra considerate to the person that you kind of want to ignore. And I think that's where a lot of this comes into play. Like, when we're talking about, race-based initiatives, everyone's like, well, this isn't fair. It's like, yes, it's going to feel uncomfortable. It is going to feel like you're giving extra special attention to the Black patients because they have been historically and continue to be disenfranchised and marginalized. So yes, it is okay if you are super attentive to their pain. Doesn't mean you're not treating your white patient's pain, because you are. But you can be extra attentive to making sure that certain patients feel comfortable while you're taking care of them. And I think that goes a long way. And, I keep coming back to sickle cell patients, because they literally come into the ED expecting to be treated like drug addicts, expecting that they're going to be dismissed, and when you already have had that experience, that changes how you interact with people. So if you can nip that in the bud right away, open with a smile, open with a joke, open with something, and immediately disarm someone, I think that can go a long way. Is it always going to work? No. Or are sometimes people just going to be jerks and storm out? Yeah. But the only thing, I think it's the only thing you can control is your behavior and the way you interact with people. And that's the first step.
I agree with that. And I would just say that I think we have to resist the temptation to triage our empathy to people who we feel like it's easier. I used to tell my residents, you don't get any credit for being nice to a nice patient. You get 0 credit for that. But if I see you go out of your way to empathize with a patient who's, maybe not so nice or maybe not so well educated that they can understand, and you have to spend a little more time there explaining something to them, then I'm going to give you some credit. You get no credit for being nice to nice people. And I see a lot of triage of care. I see how my experience is that sometimes, especially in training and even during my career as an attending physician, people see a chief complaint, they look at the description of who the person is, they throw some orders in the chart and go see that person after they've seen every other patient on the board that they want to see, because they like their complaint a little bit better, or they like who they are a little bit better, or whatever. I think there's a great temptation, especially when you're busy, to kind of triage to what you want to take care of and ignore the other people who are more difficult. So
I think there also needs to be empathy for our colleagues who, sometimes just are not very well informed around these issues. I've definitely been in positions where, my attendings have made, certain comments, or, I had a situation where an attending asked the patient who came in, who was assaulted, the night before, like, why didn't you call the police? That's the thing to do. And the patient looked at him and was like, I'm Black. Like, why would I call the police? And that was a discussion that, stepping out of the trauma bay, that I had to have my, attending sort of this historical, like, this is why he got kind of annoyed with you because you asked that question. This is something that we deal with. And, on my end, it was actually taken pretty well. Sometimes it may not be taken well, but, don't think that you can't educate. okay, especially if you are, better versed in these issues than, some of your colleagues, which sometimes happens, especially when, you're the only one there. Not saying that you have to do it, and that goes back to the minority tax, but, I think if you find a way to, pull a colleague aside and say, like, this wasn't really the right way, or, referring to that patient as a stickler, that's not really a cool term to say, and this is why. Because like I said, from those studies, I mean, you've got medical students out there who think that Black patients' skin are thicker than each other, than white patients' skin. And so, that's how they're taught. No one's telling them that there's a different way to look at it. No one's telling them that there's actually a different perspective that they can have. And sometimes if you have that understanding, you can give them that different perspective. And I think that's, these little micro changes that we can make a big difference.
I just wanted to add, I think that it's okay to tell your patient that you're their greatest advocate that day. Like, I'm going to be an advocate. I'm coming in here. Like he mentioned it earlier, Zachary said it. And I think that it's such an empowering feeling as a patient. I've been a patient. I've had my mom be a patient. And to know that somebody is coming to bat for you is important. And I think that that's easy to establish. It's kind of like it goes along with the compassion, but I'm saying like actually using language that sounds empowering to go along with the action of being compassionate. The other thing I was going to say is ask better questions. Like we need to do a better job of asking questions to be able to meet people where they're at and restoring some degree of humanity to the specialty. In medicine, we're also like, all right, belly pain, I'm going extremely targeted and I'm leaving things out and I'm just trying to get these numbers down and hit all of my metrics. Just taking a second to go back and asking the right questions, ones that can give us better insight about people. And in every interaction, every encounter you have, if you are a non-Black provider and you're asking these questions, you're learning. If you are a Black provider and you're asking these questions, then you're figuring out how to advocate better for these things. So asking the appropriate questions are better questions than what we typically do on an exam. And I think that the last thing I would say is we will review a case to the nth degree. We will talk about whether there was a mistake in management. We'll talk about whether a resuscitation went wrong. We'll do all of that. But we very rarely review things that have racial, ethnic underpinnings. And that's something that is wrong. I think that in doing that, over time, you improve the entire experience of the emergency department, even at the patient level, because people will be aware of the things that they're doing wrong and see the trends because you're addressing it in real time rather than waiting for some type of like broad DEI statement or broad policy shift. You can do it right then and there. Call everybody to the trauma bay and say, hey, I want to talk to you guys about this one issue. Or, hey, let's go to the ambulance bay and talk about this stuff. For the folks who are in the East Coast, I know it's cold, don't go to the ambulance bay. But if you're on the West Coast, you can go to the ambulance bay and have this conversation. And in doing so, it takes the ability to navigate this in a very sophisticated way. You can't just start pointing fingers out and saying, you don't know what you're doing, you're a racist. You have to be able to navigate it in such a way that empowers the thought of being someone who is aware of their own biases and wants to grow in their ability to have equity or to perceive things through a lens of equity.
Italo, that's an interesting comment. At GW, they've just established a equity M&M. So they're using the framework of the Mortality and Morbidity Conference, and we're gonna have these equity mortality and morbidity conferences. The issue is, it's a delicate start because people don't want to.
Very much so.
People don't want to, they don't want to put it out there, but we're trying. And I hope.
Hey, no, bless your heart. That's important.
And I think we just need that first case to make it fly. We need that first case. So if any of the GW students, I swear, if you are even walking by the ER and you happen to see something, please send me personally an email. You can do it anonymously, and I'll put that in for an equity M&M. We got to get our first case going here.
Right. And I think we just added that to the action items, right? Take that back to your programs, make sure when you're, and this goes back to making this part of core EM, as much as we look at EKGs and we talk about Wells criteria, is there an equity criteria that you use? Is there a bias criteria that you're using in your program? If you're not, create it. right? This is what it's for. Like, create these things. You know, if no one's doing it at your institution, do it. And I just say again, this is such important work. And I just want to thank all the panelists for this. Again, I know we went over by about 30 minutes, but this is obviously an ongoing conversation that we need to have. And we will have more of these conversations. And I think someone's asking about putting the emails in the chat, and we definitely will do that. But I just want to thank everyone again for taking the time to be here, to listen, to learn, to educate. And just thank you so much. And I hope that you all go back to your institutions and you make these changes. Even as small as they are, they will make an impact, right? Thank you guys so much. And I'll put my information in the chat as well.
Thank you so much for
excellent. Thank you. Thank you. I appreciate being invited. Oh my God, this was awesome. And I'm telling you, just scanning the pictures of you guys, it gives me great hope, because my career, I mean, I'm 30 years in. I ain't, I need y'all. Y'all got to be.
Thank you.
Thank
when
you.
I come to
Thank
the
you.
bar, I don't want no shit.
I just want to squeeze in a little thank you at the end, just before everyone signs off. Just on behalf of the whole MSC, just thank you to Dr. Campbell and all of our wonderful panelists for taking time out of their busy schedules tonight. I know everyone, me included, I got a lot from this talk, and I hope everyone else has as well. Just a reminder that we have some action items in the chat that everyone can take a look at. I'm going to put our YouTube channel and our Instagram in the chat as well. The recording will be up there, and you can look out for other events as well. Thank you all for coming, and we hope you have a great evening.
Yeah, and I just want to say thank you guys for inviting me to do this. And just, the planning process was just amazing. And you guys are doing amazing work. And like I told you before, I'm always a resource for you whenever you need me. Thank you.
Thanks so much. Absolutely.
Thank you.
Good night, everyone.
Night.